Hello, good night, and welcome everyone to Healthcare 2.0, where we are on the search for a new prescription for healthcare in Trinidad and Tobago. What we're really trying to do is to bring together stakeholders in healthcare to really find a way to improve the health services for the patients, for healthcare professionals such as the doctors, nurses, midwives, and pharmacists, and others who work in the healthcare sector. And we are trying to also tackle the elephant in the room, which is something that many of us may not want to speak about. But the elephant is in the room is really the actual healthcare system that we've been using from the 80s and the 90s, and we have made a lot of cosmetic changes to the healthcare system. So what I want you to do is now share this live with your friends, your colleagues on Facebook, on YouTube, and let us try and have that conversation here tonight with Mr. Idi Stuart, who is the president of the Trinidad and Tobago Registered Nurses Association, and I know he has a lot to say about the healthcare system and how it impacts the nurses. So I want you to share this live tonight with all your friends, all your colleagues. You don't have to only send it to nurses and doctors and pharmacists. Send it to all of Trinidad and Tobago, so that especially those of us who are healthcare professionals and we may be abroad studying or working, I'm sure they would like to listen to what's the status of nursing in Trinidad and Tobago in 2020. So we have the president of the TTRNA, Mr. Idi Stuart. He's the defender of nurses, and he's here tonight on Healthcare 2.0. And definitely, I'm sure he has a lot to tell us tonight. So in a couple seconds, we're going to be adding Mr. Idi Stuart to our stream. And let's continue to share the live and send it to our friends and our colleagues. Hello, good night, Mr. Idi Stuart.
Good night. Good night. Good night to you and your listeners. Navi, how are you doing?
Good, very, very good, Idi. Nice, Long time no see.
Yes, yes.
Very good.
Well, having a pleasant night.
Yes, yes. So far, so good. We definitely, a couple of weeks ago, we had Dr. Tarif Mohammed. He is a doctor who is in residency in Canada right now, and he has written a lot about the healthcare system from a perspective when he was working here as a junior doctor, and he wrote some articles in the Newsday, and then I read the articles and it really resonated with me. And then a lot of what you have been saying over the past few years, it has also resonated, because we all we have worked in the public healthcare system, and of course we want to see it improved.
Definitely.
Yeah. So Idi, let us tackle some of the issues that you have been addressing together with the TTRNA for some time now, and I saw this on the TTRNA Facebook page. So the issue with the several junior nurses who were employed since March 2020, and they remain on these 3-month contracts of employment. What has happened to that since then?
Well, I think that is an opportunity to demonstrate, that kind of exemplifies the problems nursing and midwifery personnel in Trinidad and Tobago face. The mere fact that a government, a regional health authority, state body, could see the rationale or see the find justification to hire a nurse on a 3 months or 6 months or even a 1 year contract on an ongoing basis demonstrates the respect they have for them, or the little respect they have for them. They would not do that for any other personnel, any other professional, but they would definitely do that to nursing personnel. So that is really the crux of our battle, ongoing, relentless battle in Trinidad and Tobago, that an employer would see the need and be able to do it so brazenly, to hire someone on these short-term contracts. They would not do it for police, fire, army, what have you. These positions are permanent positions, yet they do it to nursing personnel for whatever reason. Many reasons has been postulated why they continue to do it. Wouldn't really want to say what some of those reasons are, but they persist, and we have no choice that we are forced to demonstrate sometimes. We go to the courts. We have actually up to this evening, I was preparing for court, to take some of those matters to the industrial courts, against a particular RHA who is known to, they actually have stopped offering permanent contracts, permanent employment, and they are totally, they have no qualms about employing someone on a continuous basis for 6 months to a year. And that's the state of our situation. We would have written to the Minister of Health, we would have written to the Prime Minister. We saw some headway leading up to a mass demonstration we were supposed to have on July 1st of this year. Unfortunately, there were some riots just before that, the day before, so we end up having to call it off. It's unfortunate that healthcare professionals have to resort to these types of demonstrations when our real love is to remain within the clinical setting and do the work we were trained to do. But unfortunately, when you have an environment where a nurse could be working 10 years in our healthcare system, and that nurse would not be getting a gratuity at the end of her employment or getting a pension at the end of her employment. So when their term comes to an end, they will be retiring from a government service. This is not private or anything. This is government service. They will be retiring without any pension, without anything. And the governments, successive governments, well, I came in around 2016. So I would have met the PNM government. And they have no problem with that going on. So that is really our battle. And that is just the tip of the iceberg, and it kind of filters down into all of the other challenges that we face as nurses and midwives, all categories of nurses and midwives.
Idi, this issue with the short-term contracts, I know the doctors also had some issues with that. I know doctors who are on 3-month contracts, they said they came in to assist with the whole COVID pandemic and so forth, So across the board, you are seeing these short-term contracts. And do you think that this is the new norm with the healthcare professionals, that they can use the COVID and say, well, we can give you these 3 months and 6 months, and then we will see what happens?
Well, the whole issue with the COVID and those particular contracts, this started even before that for nursing personnel. I'm not sure if it's started with doctors also, but it started even before, long before COVID. I'm speaking about 6 years this is going on, where you have these short-term contracts. In fact, close to 10 years. In one instance, I actually have a case that we have at the industrial court, 10 years of continuous 1-year contracts, 10 years. And we would have filed that case about in 2018, and we in 2020 now. So that nurse has been working 12 years continuously on short-term contracts. Actually, Deborah Thomas Felix, the industrial court, the head of the industrial court, actually spoke to the guys that employers are doing, and she actually highlighted government, state agencies who are really culpable in this new. So, and the government through the former Minister of Labor, the Minister of Labor, she addressed, speaking about if we, then we need to do better and be asking the private sector to do better when the government itself is the principles for short-term work. It is for a specific job. It's contract laborers to get at the end of that, they leave, and it's by no means short-term. In fact, it is growing daily because we have been unable to address some of the systemic issues in our healthcare or rather sickness care model that we have running to really be able to say we go in the opposite direction, but is one direction we have been heading, which is increasing more and more persons onto the needs of our healthcare. So it's not going away anytime soon. And the mere fact the government could spend billions of dollars, $1 billion for the Point Fortin Hospital, $1 billion for the Sandy Grande Hospital, $1 billion for the Coover Children's Hospital, $1 billion for Roxborough Hospital. The mere fact they could put down all these billions of dollars for permanent structures, yet have the staff who's working in these permanent structures on a temporary basis is really is a misnomer. Yeah.
Yes.
So,
It leads us to the next point, and the next point being that also on the TTRNA Facebook page, you all mentioned that over 10 nurses had resigned from the North Central RHA in 1 week, and then dozens of others over the last month, and then 200 nurses had to be interviewed to replace the nurses who left. So tell us more about that.
Well, the NCRHA has been one of those organizations who we have had a sort of tenuous relationship with, because they were more culpable in how they all workers, but we focus on nurses and midwives, and they relentlessly pursue the cause of short-term employment in various forms, in employment, short-term, as much as day-to-day contracts. Day-to-day, if you work today, you get paid for today. If you don't work today, cool. So they were one of the RHAs who have perpetuated the short-term employment. And we were only highlighting what would be the end result. And the end result is that, like all persons in society who would be seeking out stability in their employment, would look towards a more stable form of employment. So they generally do what they are accustomed doing. They migrated to the other regions who are offering them, well, with the opening of new facilities. How fortunately we would have had this, and we are looking to address some of those issues. To see how it goes, and you would have seen the NCRHA beginning to change some of their policies that they have been implementing over the years. Unfortunately, with a new general nursing manager coming on stream in the NCRHA, hopefully those practices don't reoccur in the future. But
Yes.
in any event, whether they leave towards another area, from the minute the borders are open, you're going to see a mass exodus once again of nurses leaving to greener pastures. And that's the way we in the Caribbean have always faced migration of our nursing personnel, because of not only because of the compensation that is afforded to us by England, Canada, US, Abu Dhabi, wherever, but because of a number of other aspects that that is deficient in Trinidad and Tobago: education, upward mobility, the sense of involvement in decision making. You don't get that in Trinidad and Tobago. So there's the world is the oasis for nursing personnel. Actually, we have over 5 nursing agencies have approached the association to assist them to recruit nursing personnel. So with that type of interest from these agencies internationally, nurses would see the benefit in migrating. So the association would not want to urge nursing personnel be focusing on improving the quality of healthcare in Trinidad and Tobago. And to do that, you need a competent nursing staff. So if we keep training and they keep migrating, we remain in the situation we currently are in right now, where you have a majority of junior persons on the wards. Yeah.
What Dr. Tarif Mohammed, who I told you 2 weeks ago, came onto the show, and we were having that same conversation with respect to the doctors. And I was explaining my situation to him, where many of my colleagues who I would have studied at Mount Hope with, they are now abroad. They've gone into programs, they've settled down, they're happy, and they have no intention of returning to Trinidad. And they have then specialized in some areas that I think we need in Trinidad, but there is no opportunity for them to come back. And I think that brain drain is real with the healthcare professionals, doctors, nurses, across the board.
Yeah, definitely. I even myself have been persuaded to go abroad myself, but one or two issues is present right now. So I committed to TTRNA, but even myself might leave eventually. But that's not really the focus persons really should be. And I would have heard you repeatedly, and really want to try to build our own nation first.
That's right. That's right.
But it's an uphill task. It's really an uphill task. So those who remain really must be commended for remaining and staying the course. But because the options are so many and so numerous abroad, I did oncology as my specialty, oncology nursing at UE. And when I did my internship, a month internship at Mount Vernon Cancer Research Center in England, I was amazed at the level of nursing that is being done internationally. I would have witnessed when we were sitting in some of the sessions between the doctor and the patient, the doctor would have spent about 10 minutes with the patient, giving the patient her diagnosis, and then that he referred the patient over to the nurse, specialist breast cancer nurse. So not just oncology nurse, but particular part. And the nurse went on to explain everything else about what type of care, what type of treatment you'll be getting, everything nurse went. And oncology units, the chemo, you have witnessed nurses doing basically everything, body testing, initial testing of the lab specimen, the blood specimen before starting. They did literally everything. The only time the patient saw the doctor is when it's time for review, for diagnosis, or time for surgery. Everything else was the nurse was involved in. When I came back home to Trinidad and Tobago, I was amazed that we were kind of relegated to moving notes around. And we moved the notes from the medical records to the doctor there, from the doctor there, so back was this. So it was an eye-opener for me, and Well, still want to practice the skills I would have learned in oncology. So that is, and a number of nursing personnel are in the same light. And it's only because of probably schooling for children or some family relative you're taking care of that why most persons haven't gone again. But TTRNA is committed to try to make some of those opportunities available locally for our nurses and midwives so they won't have this massive brain drain in Trinidad going on.
Yes, yes. So you made the point about the brain drain, and I mean, all of us, we are healthcare professionals, the doctors, the nurses, we all have opportunities abroad. And as you said, in the morning, if you really are serious about it, you can apply, and where you would have trained, they love to take their trainees back, especially after a few years of experience. But many of us, we have committed to stay in Trinidad and Tobago and work in a very difficult healthcare setting with all of the limitations. So we will talk about some of the solutions later on. But there was something that was a little troubling when I saw again the TTRNA post, and it was mentioned that several patients were awaiting to be admitted into the ICU from the high dependency unit, the HDU, and the 6 beds were filled in the ICU. This would have been about 2 weeks ago. And then it went on to say that the majority of patients who died never even made it into the ICU HDU due to a bed and human resource shortage. Now, that is that's a very serious situation, because if you follow the whole COVID pandemic on CNN or BBC and you look at other countries, yes, there would have been a shortage, and maybe they would have created something similar to our parallel healthcare system. But if this is the parallel healthcare system you're talking about, where we're having these challenges, then there's something really, really amiss going on there. So you want to elaborate on that?
Well, well, the problem really stems with, in terms of human resource, because I think the facilities are there. Because we have a number of facilities, a number of billion-dollar facilities. I'm not even sure how we're going to fund those facilities in the future, but we have a number of them. The problem relies in the human resource, and we just don't have enough trained HDU, ICU nurses, critical care nurses. We just don't have. We have never had enough, and it really stems with the training, limited training opportunities. There's one school in Trinidad and Tobago that trains critical care nurses. In fact, in a number of those special schools, that school is the Ministry of Education.
Idi, your microphone is on mute. I think you need to check the microphone. Yes. Yes. You were making the point.
Yes. Yeah, as I was saying, so you would never find, there's actually, I was just going, the Ministry of Education, the only category of staff that is trained by the Ministry of Education directly is our nursing personnel. There's no need for them to do it, yet they are the only organization. It's not really a school, it's not really a tertiary level education school, which is recommended by International Council of Nurses, recommended by ILO Nursing Personnel Convention 157 and 148. It's the best practice is for nursing personnel to be trained in the same environments as where their counterparts, where the other persons in the disciplinary team would be trained at. So this is why they ought to be trained in UE and USC and UTT, not upstairs a mall on Frederick Street. That is where our critical care nurses are trained, upstairs a mall in Frederick Street or in Palms Club in San Fernando. And again, it goes to the root of nursing, and they view nursing as just another pair of hands and not as a professional in their own right who could make decisions. And this impacts on the overall care, because then the other persons in the multidisciplinary team also would now not see the nurse in that light and just see them as a pair of hands. And then once you get that indoctrinated in the nurse mind, the nurse will then see themselves as just a pair of hands, unable to think outside the box, make decisions, and they rely on the doctor or the pharmacist to make all the decisions, and then they would not step up to the plate. And we see that far too often with our junior nursing personnel, where clear errors on the part of other healthcare professionals, they would not question or they would not pick up because they haven't been taught to confront those issues and say, well, no, this must be a mistake because the body percentage of this person is lower than what it's supposed to be. So it's a whole ripple effect, and it really speaks to that shortage of critical care nurses, is the lack of training facilities in Trinidad and Tobago. I know UE is trying to ramp up through the School of Nursing, trying to ramp up other specialties in nursing. And hopefully that comes on stream as fast as possible to move away from when the government decides to train another batch of critical care nurses. Yeah.
Yes. You have mentioned again that the nurse administrator at Couva, who was there since March, had been transferred, and there was no post, there was no vacancy, and so forth. What has been the outcome of that?
Well, that issue has been rectified. That issue has been rectified based largely on some of the agitation we would have done, based on some of the responses from nursing personnel within the institution. And actually, the person who was going to replace her actually said, look, if that is the environment, if that was the reason that I am getting this position, then I really don't want the position. So that the authority had to backtrack off of that. So the quite competent nurse administrator at Couva remained, who has been doing great work since the start of this COVID, has been doing great work. And we would see the type of work and the type of stress that some of our colleagues are under, nurses and midwives and nurse administrators have been under since this whole COVID scenario. The association is watching and waiting. When it's time for national awards, who will be the ones given national awards for service to country? You could actually, over the years since independence, since the national awards have been given out, you could count on one hand the number of nursing personnel who have ever been given national awards. And there's been national awards for every other category of person in Trinidad and Tobago, from sports, music, all other areas, long service merit awards, but nursing personnel don't seem to find the relevance to some of our leaders that the role they play is worthy enough. So, well, it's an uphill battle. It's something that we have to do, and we continue to do it.
That's right. Idi, the whole question of the nursing council and the relationship with the two arms, I would call it the TTRNA and the PSA. What is that relationship like? Because from where I sit as a medical practitioner, we have our medical board. We don't have a union that is active, as far as I am aware, MPAT. I haven't heard anything about MPAT for quite a long time. We have a medical association, but they deal with more of the education and the training. But where it comes to the nurses, you have the nursing council, and then you have the unions that represent them. Not everyone listening may be very familiar with who represents nurses. So maybe you want to give us a little background on that and explain that relationship so we could understand it a little better.
All right. So prior to 1994, prior to the regional health or authorities coming into being 26 years ago, where all of us would have been under the Ministry of Health prior to decentralization. When nursing, all healthcare workers were under the Ministry of Health, as public servants, the Public Service Association would have represented everyone just by default, because you are in the public service, doctors included. Once RHAs came into effect, once decentralization took over, PSA never came over. Well, they were denied coming over with those employees. So for 26 years, there have been no for the RHA workers, save and except for daily paid workers who continue to be represented by so they to get scripted in the law in the RHA Act to be able to maintain representation of their workers. Each grouping had out and seek RMU status, and apply to the RRCB, registration, recognition, and certification, to get recognized as the majority union for that group. MPAT was the first to do it. They did it in South, and then they went on to do it in Eastern. Unfortunately, something happened to MPAT, so we don't know what is going on with MPAT. We know that there's a trustee, because we were trying to collaboration with them, but I don't think they have had elections in quite a while, so what is going on with them? With regard to TTRNA, we have applied for the majority union status because we have the majority of nursing personnel. And you have to get majority 50% plus one in RHA. So you need 50% of nurses in each RHA. So we have done that, and we are far advanced in that. The process is quite easy, and to surmise it, and just to bring it home, there was a recent court judgment. It's something that we always knew, but it reared its head recently with the Court of Appeal ruling once again that if you are a union and you already represent one essential service, this case was with OWTU, and OWTU, the RRCB gave them majority unions, the Salcott workers, but OWTU already represents TN workers. So it's essential TN Tech. So in the bars, a union from representing essential service and then another essential service, unless you were doing it before renewing. So that kind of solidifies that there's really no way the PSA, the Public Essential Service, which is the Water and Sewage Authority. So there will never be an option for also an essential service. Any person could join any union and be sold to any union basically and court. But in terms of being the RMU status and getting that, the union now has to get that 50% plus one. And as I said, we are kind of far advanced in terms of things. It only made sense for us to apply for. You have doctors, you have nurses, you have administrative staff. So about 5 or 6 groupings. And we are applying just for all the nurses and the RCB get through their process. As already applied, and we're still in the process. Let me tell you the difficulty in accessing that. Somebody who determines whether or not you get RMU status or not. So it's very onerous. The Nursing Council is the regulatory body, as indicated. And they have had some issues. I was also on the Nursing Council the last period, and I would have witnessed and seen some things which I wasn't in favor with. And that culminated actually in a court matter before the nations, before the High Court. So, but, and that takes me to one of my main issues with this whole health sector is the lack of regulation in our health sector. It's a kind of free fall. Accountability is nearly absent in the health sector. And this again coming from doing a little internship away, this is also coming from persons who come in, seeing our model and saying, but what is going on? Actually, I had a colleague who works for the it's a body set up in the UK following some deaths that occurred in the UK. He was asking me a particular question. He was asking me if an individual, who can they go to complain against? So if they housed in Eric Williams Medical Science Complex and they didn't like the treatment they got or their relative died, who do they go and complain to? And I had to tell them there was really no one. You have to complain to the very region through the quality department. You have to go to the very quality department who works for the same employer to complain on that very organization. And he couldn't understand. He said, no, there must be some independent organization external to the regional health authority who you go to complain to. And I said, no, there's none. So, and every country would have whichever authority. Most developed countries would have it, I guess. And the developing countries is a work in progress, and groups like TTRNA and yourself would have to be pushing for these things to gain some form. Because right now, if the quality and the government actually, this was also part of the rationalization, all part of the decentralization, health sector reform, having that independent group. Supposed to have a quality assurance board set up to monitor a quality council to do that very job 26 years later. All we really have done is decentralization. It's just split up the Ministry of Health into 5. Now we have 5 CEOs, 5 boards, 5 chairmen. So more money is spending, but the quality has not been done. We will when we were just the Ministry of and there are other aspects of never got off the ground with the National Health Insurance System. We have the regulatory bodies. I and all complained to the medical board about a doctor, and all we received was a letter stating we received your letter and it's being looked into, and that was the end of that. And it's the same thing with the nursing council. Some person don't even get a response. In fact, there has not been one single nurse who has been disciplined by the nursing council board in the past 6 years. And that is just from information I have. It could be much longer than that.
Yeah.
And that is unimaginable. If you go right now, if persons go right now to the NMC website, they could actually see the nurses who have been disciplined right up on the NMC website, and you would see what they were charged with, when the case was heard, what was the repercussion if their license was taken away for 5 years, if they were placed on retraining. You could see all that visibly. So that is where we are. It really lacks regulation in all aspects. In fact, that whole Brian Lara cancer treatment level, let me not call the name, but that cancer treatment facility is a prime example of the lack of regulation because that's the real role of the Ministry of Health. Their role is regulation, healthcare financing, providing that oversight, and the Ministry of Health, unfortunately, is focusing more on service delivery, which is the real remit of the Regional Health Authority. Regional Health Authority, they are charged with service delivery, but you always find the Ministry of Health saying, we're going to do A, B, and C, when that really is supposed to be the role of the CEO to be making those comments and whatnot.
Yes. Idi, you touched on two pet issues of mine, two issues that I have been, for the last, I would say, 2 decades, really passionate about. One has been, you spoke about the national health insurance, and we have had some discussion about it, but nothing really tangible has come out of it. As far as I remember, it was in mid-2000s when then Minister Jerry Nares, he was the Minister of Health at the time, he had spoken extensively about it. And he said it was coming. And then there was a change in government, and they said it would be reviewed. Then in 2015, there was another change in government, and they said by 2018, I hope you remember when they said it, but by 2018, we should have national health insurance. And it is now 2020, and we have not had that, the whole issue of national health insurance. Now, we have to do also the national health insurance right, otherwise we could end up making a big mess of it. And the second issue you touched on was the whole issue of the RHAs. And 2 weeks ago, my guest, Dr. Mohammed, he was questioning, why do we need really the 5 RHAs when there is so much red tape, bureaucracy, so many, it's top heavy. And I've always questioned that, like, why do we really need all of these service delivery organizations, and the service delivery isn't to the highest standard. So we are investing $6 billion into healthcare. It works out roughly about $4,400 per year per person in this country. That's how much we're investing in each person. And yes, there are parts of the health sector that work. There are some really good results, really good stories come out of it. So we are saying that the parts that are not working, how are we going to address that? But we always come back to the elephant in the room. And I made that my early statement. The elephant in the room is the healthcare system. The system we have been using since the 70s and the 80s. We tried to do something with the RHAs to fix certain things. That has, I think, made things sometimes worse and very top heavy, and we spend a lot of money there. So the actual money does not benefit the patients who come down to, but when you come to the bottom of the whole pyramid, the patient care, they're not receiving that type of funding. And I want to, I mean, we touched on two things there, but I want to ask you something. As a nurse, I mean, it pains me as a doctor, so I will say this, and I have had some stories in the newspapers about it. When you go to the hospital, especially like I could talk about San Fernando Hospital, and you're being asked, the patients are being asked to bring their own bed sheets and pillows and toiletries and pay for your CT scan outside and pay for medication. And you wonder, then what is that $6 billion being used for? That's a lot of money. I just told you it was $4,400 per person per year. Some people might say, well, okay, in terms of health, that's a little bit of money. But as a taxpayer, I'm being asked to bring these things to the hospital as a patient. You as a nurse, you representing nurses, I mean, how does that make you feel?
Um, well, I would have had the pleasure of of working in public and private for about 12 years. And it always marvels me the quality of service you get in some healthcare facilities in the private sector with the same exact staff, and then the quality of service you get in the public sector. Um, and but and it's so it's chalk and cheese. As you indicated, there are some aspects that work reasonably well, but there are a lot of areas, and we as healthcare professionals must admit that there are a lot of areas that need to be improved. And it is really sad when you see the fallout of what we offer as healthcare service. So is to really drive home the point, the model we have right now. And with the multiply, exacerbate the problem. The alternative, we need a couple of things to happen. We need to be a system, and then we need to bring down expenditure. How we can bring down expenditure is by keeping persons healthy. And we are lousy at doing that, the healthcare system. We are lousy at keeping persons healthy. And then on the other side, how do we get the additional income? And that's why we are pushing for the national health insurance system, which, as you indicate, have been on the cards about 20 years. The last push I saw was Hamza Rafiq. Now, I can't remember if the race was after Hamza Rafiq or before, but I remember they did a whole consultation. TTRNA was part of that consultation, and a detailed report. It was moving, and then it stopped. But I know those persons up at UWI still continue to do work on health insurance because they are working up the Caribbean, inclusive of Bahamas. And I had the pleasure of visiting Bahamas just before the COVID pandemic reached. I was there in February, and I was trying to get an idea of how this health system is working, something that was designed by Trinidadians, designed by those guys up in UWI in the health sciences department here. And it was working, it was new, but it was working. When I say new, it was like 5 to 10 years old. So the country was accepting it, it was rolling out, and those patients were able to choose whether or not they want to go to public or private. it was their choice, because now the health insurance, some persons choose to go to the public over the private, depends on which service you're going for. And I think this is something that could really work in Trinidad and Tobago. It will create jobs in the health system. We could look at higher order skills in terms of, we really don't have any tertiary care facilities in Trinidad. We basically have primary and secondary. We really need tertiary facilities. So instead of persons flying out to Miami, all of these places, you could stay right at home and get these specialized services. Um, so I think it's something that could work, national health insurance system. Um, I mean, all the plans are there. Unfortunately, I did not see it part of this present government's manifesto for health. Well, actually, going through their manifesto for health, it really didn't have anything dealing with what plans they have. So it may not be on their horizon over this next 5 years, unfortunately. So again, as groups like us needs to constantly, and to be fair, it was on both of the major political parties' manifesto. Um,
Yeah.
so that's unfortunate that both political parties didn't see the need to roll out this national health insurance system, or the quality councils, or improve the regulations, or improve um, health sector management. That's a major issue. Training our managers. Okay, we already expended all this money on creating this um, RHA system, which really has not worked. It's not more efficient, it's not more effective, it's not more patient-centered. So it really hasn't worked, but we haven't really given it the opportunity to work because we haven't put in these supporting structures. So persons would say that this whole system really hasn't worked. But I believe we have already expended all of this. If we have to go and revert to what it was before, at least let's try and see if it would have worked. Um, it's top heavy, but I mean, I don't really like to waste money. So um, although I see England kind of reverting now, because they find it hasn't worked for them, and they're a larger country.
That's right.
But so we will see how it goes. But we really need to change our focus. I always examine the health system from a customer to see if it's working or not. And I would have viewed a couple instances where my mom was really don't have any medical issues, but last year she had some issues with her dizziness and her blood pressure. So took her to health facility in the West, public health facility. Um, the the interview I find could have been better. The diagnosis was made after one blood pressure reading. That was eye-opening to me. With one blood pressure reading, you could make a diagnosis without getting any background, without any follow-up. You just make a diagnosis in one. Um, when we went to another area, she I had to fight to get into a clinic. Getting into the clinic now with this whole COVID crisis, even though the government speaking about a parallel health system, you cannot get an appointment in the health centers. When you go to the health center, they say, no, we're not seeing anyone. Come back. But you are saying you have a parallel health system. I think this health system has shut down on one. And I mean, we have to do better. I actually witnessed um, a healthcare professional using her phone to Google what could be a possible diagnosis, or what are the scale to use for hydrocephaly and stuff, and not on a site, a reputable site, just like some what are
Wikipedia.
average person would be using. And I was, wow. I said, is this our health system? There's no, I mean, you're not going to any reputable site to say, okay, we're using technology, no problem with that. You can't remember it offhand because you're junior, but you're using a site that the lay person uses. So you haven't verified. I mean, it's we have a lot of work to do. We have a lot of work to do. We have a lot of work.
Yeah. Idi, we're running out of time. We have about a few minutes left again. I definitely want to keep our conversation going because I know that we do have a passion for seeing positive change in the healthcare system, and we all have our ideas. But one of the things I would like to see, and I think maybe as the group representing nurses, as I said, I'm not seeing any movement with impact for the doctors. But I mean, we can get healthcare professionals together, and maybe we should ask for not a commission of inquiry or not another Gafoor commission, not another Welsh report, none of those things. What we would like is maybe a committee to be set up with representatives from each of the various groupings, and specifically dealing with how we are going to implement the national health insurance. So it's not a fact-finding procedure that's going to take years and papers and reports. It's going to be, okay, how can we implement the national health insurance, and what are the challenges? Yes, UE has done their research. We can look at models from all over the world. I have studied a lot of those models. We can't import anything. We know that. We have to do something very unique to us, but those other models will be there to help us. And I think that is something that we probably need to get together. And if we have to focus on one thing together, let us focus on getting the government up to date to really focus on the national health insurance through various interest groups like the doctors, the nurses, the other healthcare professionals, pharmacists, insurers as well. Everyone who would have a stake in this, and to come back and say, okay, this is implementable, this is not implementable, and this is the time frame to implement it. And if we can do that one thing over the next few years, I think it would definitely serve us well.
Yes, definitely. That's a good point. And it's definitely something the association would want to partner and be a part of. Because as I said, we're running an unsustainable model right now, and a lot of people are being disenfranchised in terms of the quality of care they are receiving. So definitely, we will want to be part of it.
So, Idi, your closing comments, closing remarks?
Well, we just would want persons in Trinidad and Tobago to be reassured that of professionals who have their interests at heart, and we would work tirelessly to improve the quality of Trinidad and Tobago, something that is patient-centered, safe, effective, efficient to persons. It's really a nightmarish scene to witness a patient die in front of you who you know could have been saved, who you know could have survived if they had quality, timely intervention. So we would continue to work the Trinidad and Tobago Registered Nurses Association tirelessly, and we look forward to partnering with any group who has the interests of Trinidad and Tobago healthcare at heart. Yeah, thank you so much for having me, Doc.
Thank you. Thank you very much, Idi. And tonight would not be your last time. I'm sure you will come back again. You just need to fix your audio issues on your side. We got a little bit of audio, so we will work on that for the next time. But I'm so happy that you took the time, and you came and you spoke to us and enlightened the general public about the issues that impact the nurses in Trinidad and Tobago. So I want to wish you a good night and wish our viewers a good night as well. So take care.
Take care.